Okay. Okay. So the meeting, hello to everybody. And the meeting is being recorded so that people who aren't able to attend today will be able to catch up and view the recording. We'll send out an email after in a couple days once the recording is processed. And that'll go to all of the Funeral Consumer Society people and all the Out of the Box people, those two mailing lists. And it will also be posted up on YouTube. Because it's being recorded, if you participate by speaking during the program, you will be part of the recording. So keep that in mind. But we are basically going to ask that you use the chat to submit questions, and then Jean and I and the other board members will monitor that chat and hopefully address everyone's questions. And then at the end, we can open it up to verbal back and forth. That's the overall. So I'm Sue Mackey. I think a lot of you know me, but I'm with the Funeral Consumer Society as the board president, and we have lots of other board members here today, almost the entire board. And I would say wave, but we're on 3 different pages, so I don't know that you'll be able to see who's who. But Lila and Dawn and Jim and Judy and Lee and Anthony are all on the very, very active members of the board, and we've been having a good time lately, just really moving some things along, including doing these webinars. And then Jean, my co-host, co-facilitator, Jean Abbott. Hopefully you read her bio in the marketing materials that came out in the email. She is self-described as a recovered ER doc. So you'll see that she can walk both sides of the fence, having been in the mix of it all. Obviously lots and lots of experience. And so I'm really most grateful that she's here to be able to share her hands-on experience around these issues of CPR and the MOST form. What else do we need to discuss before we get started? I'm assuming that many of you have seen the two New York Times articles that came out yesterday, very timely, and one addressing issues of not having a DNR order or medical orders honored. And another that was very helpful, I think, on getting to know what you need to know about a DNR. So we will be getting to those issues later on in the program. We can have an agenda. We've got a PowerPoint and an agenda. And so we know that we will get to those issues. And then, of course, we wholeheartedly really love engagement and questions and inquiries and such, and involvement, so that we can make this more informal. Okay. We have a PowerPoint. I'm going to start off the first half of it or so, talking about CPR and DNR and what they are and all of that. And then Jean's going to go into detail on the MOST form. If you're not familiar with the MOST form, you will be by the end of the program. And we're going to bounce off of each other. And Jean's got lots of good stories, real world stories, which is super helpful. So I think I don't think there's anything else we need to do except to bring up the PowerPoint and cross your fingers that I get the computer part.
Always the most challenging thing.
Yeah, absolutely. Here we are, share. And
you might want to mute everybody.
Oh, thank you. Thank you, Jim. That was Jim, our treasurer on the board. And I appreciate you all being patient with me. And darn, I know that I can have you still see Jean and I.
I'm seeing the first panel.
The first slide.
No, the first panel of people, which
right.
includes you and me.
Let's see, share screen, advanced. Hang on just a minute.
If people would put their speaker on or the view of speaker, they'll see the speaker.
Oh, thank you, Jen. That's easier. Would everyone do that?
Civil War.
Just put on speaker view. Do you know how to do that? Click on Jim, jump in here.
Up in the upper corner,
Area
there's
shows beautiful landscapes.
Okay. All right. Are we all set? You've got speaker view on, folks. And so you'll be able to, we won't just be listening to blah, 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 blah.
A variety of natural trails.
Oh,
somebody isn't on speaker.
Michelle, did you have something you wanted to share? You can jump in real quick.
Charleston, South Carolina.
I don't know what that is.
Somebody isn't on mute.
Right.
Founded in
Third.
1670, it played a significant role in the nation's historical trajectory.
Could everyone please mute?
Yeah, everyone go
audio?
ahead and mute.
Mute.
Okay. All right, are we good? All right. Always got to have a glitch just to get going, but thank you everyone for your patience, and we are going to proceed with our webinar on CPR directives and the MOSE form. So. So what exactly is CPR? All right, I was on mute somehow.
Yep.
All right, do over. What is CPR? For those who are not familiar with the terminology, CPR stands for cardiopulmonary resuscitation. It's a medical procedure, and it is a miracle procedure for someone who is younger, in good health. It was originally orchestrated as a procedure that could be done on someone who had suffocated or been electrocuted in order to get their hearts beating again. And which is a wonderful thing when you're young and healthy and your body is able to recover from the procedure itself. It is performed on people who have died. You have physically died, your heart has stopped, your breathing has stopped, and CPR is an attempt to bring a person back to life. So the goal of CPR is to return people to their previous state of health, but there are different outcomes other than being able to be brought back to your current state of health. One is that the CPR won't work and you will stay deceased. The second is that the CPR attempt will get your heart started again, but you'll end up in the ICU because of all the procedures that are part of that. And oftentimes people who then end up in the ICU will have another heart event and die again. The third option is survival of the CPR. But with a hospital discharge with good neurological function. And we're going to keep talking about that because it's really important. It's a key to all of this, making decisions around all of this. And then there is the fourth option of going into the ICU, surviving to hospital discharge, and having poor neurological function. So and important to know that the CPR attempt does not address the issue of why the heart stopped in the first place, which is why it's not uncommon for someone to have a subsequent cardiac arrest. So some of you have probably witnessed CPR, not very many of us, and it is an aggressive procedure. Yeah, there's 100 compressions per minute must be applied to the chest. depressing the sternum 2 inches down and to the beat of the song Staying Alive. And you're usually intubated so that to help you breathe. So a tube is put down your throat. There's injections into the heart. They need to sedate you so that you don't pull that tube out of your throat if you are resuscitated. There's IVs, the defibrillator paddles. There's a lot going on, and it is very aggressive. Some have described it as violent. So some of the things that can happen if you have a CPR attempt done to you is that your ribs and sternum fractures are very common. Statistics range from 60 to 97%, which makes sense. 2 inches is a big push on the chest. If the ribs or sternum fracture, they often will perforate the lungs or the spleen or the liver. So now you've got recovery for those organs. The upper windpipe, because of having the intubation tube put in, can damage the esophagus or the windpipe. You can be burned from the defibrillator, so you have skin burns. Sometimes there can be damage to the lips and the teeth from the breathing mask and from the tube. And 50% of the time, there's irreversible brain damage. So DNR, what is DNR? We interchange the terms CPR and DNR, and hopefully by the end of this you'll have it straight in your mind how to use the terms properly. But DNR, as in do not resuscitate, equals no CPR attempts. Do not attempt CPR. So it's very specific. Excuse me. A DNR is specific to your heart or breathing mechanisms stopping. It has nothing to do with any other kind of treatment. It is just for the instance of your death based on cardiovascular system stopping. When you're in the hospital, we call it a DNR. And so it's a DNR order that the doctor determines that resuscitation, CPR attempt would be futile. They'll put that in your record that you're a DNR. If you leave the hospital, then you would still like to carry an order that says, I don't want CPR, then that order has to be translated onto a different form that you carry, that you have with you in your home. And we'll talk more about how to make sure that somebody knows you have that form. And that form is called a CPR, or it's called a CPR order. So I hope that that's clear. They are different forms. They accomplish the same thing. And if you take nothing else from this, know that there just needs to be conversations around these things. If you go into the hospital, especially if you've been carrying a CPR order, if you have one already, then when you go into the hospital, you want to have a discussion with your physician about whether or not it's appropriate for you to have a DNR order in your record while you're being hospitalized. And then again, when you're leaving the hospital, if you've had a DNR order in place, then you want to just have a discussion with your physician around having this paperwork done so that you have a no CPR out of hospital. Okay. Unfortunately, these discussions don't always happen initiated by the physician. So that's why we're doing this, so that you guys know how to be good advocates for yourself. Just know that if there is no DNR or no CPR order, the default is to do CPR. That's our medical system. Our medical system is there to keep us alive, and that's their intention. And unless someone intervenes, that is what will happen. So if you do want CPR, if you've decided that it is appropriate for yourself, you don't have to do anything because that is what you'll get. Important to know that reversing a death, as in bringing you back from death with CPR, is not the same as restoring a life. And statistically, as many as half of patients who have survived CPR say they wish they never had it, even though they're alive. They're not happy with their quality of life, and they wish that they hadn't had the CPR. And I'm sure many of you have seen statistics or articles about doctors who have said that they themselves would not choose to have CPR. This is TV has been our education around CPR in the past. We're certainly talking about these things much more now, but I don't know where all these good hospital shows have gone, but you see what the survival rates are here for CPR, and they're pretty high. That's not the real world. This is the real world. Abysmally different than what happens on television and movies. So these statistics are overall statistics that that are combined inpatient and outpatient statistics. And inpatient, generally the statistics are a little higher because there's more immediate response time than when someone goes down in the grocery store or is found down in their home. So overall, about 15% of people live through CPR, which means 85% die. So it is not a terribly effective procedure, but not worth trying when someone is appropriate for it. The definition of survival, very important when you're looking at the statistics in articles or whatever you might be reading, is that survival simply means the heart is breathing again, period. It doesn't necessarily mean that the patient's alert, awake, able to talk, but they are just physically alive. So the question is, what is the quality of life following a CPR attempt? People who are older, who are frail, who have chronic medical illnesses are much less likely to live. And the reason being that the category of individuals, they're less likely to have a heart that's strong enough to recover from an event like this. And they're also less likely to have the type of heartbeat that responds to CPR. So there's different reasons for people to have a cardiac arrest. And if any of you guys have questions around these things, put it in the chat because Jean's the one that can answer that. Things like type of heartbeat. And these people are much more likely to be harmed by this type of procedure, and their organs are less likely to be able to recover from the medicines that they use, the liver and kidney that have to process through medications. They're less likely to be able to process through the very strong meds that have to be delivered to try to get the heart going again. So another statistic is that adults who are over age 67 and with severe chronic disease, only 2% of them are alive in 6 months after CPR. Now that would be a combination of things, that they're living with a chronic disease to begin with, but then having the CPR doesn't really benefit them. I guess it depends on your perspective. Maybe 6 months is a good outcome, but 2% is not very significant. Age is definitely a factor, and other factors are the reason that the heart stopped, as we said, how healthy or sick the person is before the heart stopped, and people with chronic illnesses and such are definitely lesser positioned to benefit from CPR. And the other issue is how long has the heart been stopped before CPR was started. If someone has a heart incident and their heart stops and no one finds them for a bit, much less likely that any kind of CPR attempt is going to be effective. Brain damage can occur, meaning anywhere from mild memory loss to a full vegetative state. It happens in about 40% of hospitalized patients. So, and yet, if a person is in the hospital, and this is important, if you're in the hospital, the default expectation is that you will get CPR. You're considered a full code. And you've probably heard that terminology in film or whatever. Full code means, yes, we will do CPR on the person. So there's an assumption made that if you're in the hospital, you are there for treatment and you want all treatments. As I hope maybe gleaning from this is that CPR as a treatment is very differentiated, and it's not in the same category as giving a person antibiotics or doing a surgery or other type of treatment. So some good news is that we're trying to move to new terminology. And instead of saying DNR, do not resuscitate, which implies do not treat, or no CPR, they're moving to new terminology, allow a natural death, an AND. So it's slow go, but we're working on trying to get that terminology changed, because there's no implication of avoiding other treatments. So what are your chances of survival? More statistics. I've got different approaches to the statistics in here, just to whatever impacts you, where that it makes sense to you. So you can see here that survival to hospital discharge has a separate column from survival to hospital discharge with good neurological outcomes. And the statistics are pretty darn low. Inpatient higher at 8 to 14%, and outpatient, as in you have a cardiac arrest at home or in the grocery store, 3% survival to being discharged and having good brain function. We all want good brain function. So how do you make the decision about a do not resuscitate, do not resuscitate order? General advice, and I'll have Jean jump in on this also. My understanding is that very, very, very roughly under age 60-ish, you very likely will want to have CPR attempted. If you're in good health, you don't have severe osteoporosis, which obviously would be a reason for much more bone cracking and fracturing and such. Under age 60, it's fairly clear that you would want to go ahead and have a CPR attempt. Over age 80-ish, and that's a very big-ish, 80-ish, CPR is not a great idea. If you want to have a peaceful death. So that's, and then in between, in your 70s or 80s, it's a tough decision to make. It's a decision that needs to be made with your physician. And we'll talk a little bit more about that. One of the things that you're going to consider when you speak to your physician is, what are your goals of care? So you can see this chart that CPR is appropriate if you want to live regardless of your medical conditions and regardless of your quality of life. If just being alive is your primary goal, then CPR is appropriate for you. If comfort is not your primary goal, if you're willing to risk some decline in neurological status, that's a biggie. That's a big piece of this. If you have a high pain tolerance and tolerance for trauma, because the procedure is traumatic, and some people they feel like they have to do everything. And so CPR then is appropriate. CPR is not appropriate when longevity is no longer a goal. So that comes into play for hospice patients and people who are in their elder years, and where longevity is not the primary goal. Primary goal would be comfort and quality of life. If dying peacefully or naturally is a goal, then CPR is not appropriate for you. You can look at it this way, that if you have had a cardiac arrest and died, you just got a peaceful, natural death, which is what most of us, you take a survey and that's what people want. They want to die naturally. They want to die peacefully. And that a cardiac arrest in the scheme of things, is a pretty good way to go. So if you then have CPR administered and end up back in the in the ICU and such, and then possibly dying again, you've been deprived of having that peaceful dying process. If you're trying to avoid a prolonged dying, such as an ICU death, CPR is not appropriate. If you don't want to risk having neurological impairment, having brain damage, then no CPR. Again, avoiding trauma and pain, and that's the decision process. It is what are your goals? Longevity at all cost, having a peaceful death, a goal of comfort, and what would your goal be, or your tolerance be, for a neurological issue. So making a decision about this, doing your research, talking to other people, knowing what the statistics are, knowing your health. We highly, highly recommend that you have a conversation with your physician in order to make a determination about having a CPR, an out-of-hospital CPR order that you would keep on your refrigerator, and have other ways of communicating that you don't want CPR. I think most of you know that Medicare now has a code that you can have, so that when you have a discussion with your doctor about end-of-life care, they can put in a code to Medicare and get reimbursed for that. If you call ahead next time you're going to see your physician and let them know you'd like extra time for an end-of-life conversation, or I think your Medicare yearly includes that. Anyway, it's really important. I urge you, if you're in that gray area of 60s, 70s, have a conversation with your physician about your particular health, your body, share what your tolerances are, and ask about what your expectation might be as far as quality of life following a CPR attempt. Again, just remember that a CPR order and a DNR in the hospital are similar, but if you're speaking to your physician about a CPR order, that's for what you would have while you're out of the hospital, to indicate that you don't want the paramedics to do this procedure on you. Jane and I are going to talk later about CPR directive being honored. It's a little bit confusing, and so I'm going to postpone that for a bit, but the CPR order, the form is to be signed by your physician. And there's a little bit of grayness around whether or not you can just have no CPR written in your own hand or in an advanced directive or even on a napkin, and if that will be honored. So we'll go into a little more depth on that. But first step is making the decision about what's appropriate for you. And then what happens when you've got to make a decision about CPR for someone that you love, when you're the decision maker, and the doc wants to know if the person's in the hospital, if they should do a DNR, or designate them as DNR, or if CPR would be appropriate for them. It's a tough decision when you're deciding for someone else. It's hard enough to make the decision for yourself, and then to decide for someone else when you're the healthcare agent and it's someone you love, and oftentimes we just want to keep them alive at all cost. And so you're going to be having a conversation, hopefully, with the doctor about what would be the benefits of having CPR and what would be the burdens. That's how we weigh our treatment decisions: benefits versus burdens, on a scale. And if the potential downside outweighs the potential upside, that it helps make the decision a little more clear. You want to consider whether or not the person's ever mentioned whether they wanted CPR. It's possible it might have come up in conversation, or in general, whether or not they want their life extended with interventions. You want to consider how sick the person is, and if they're at the end of their life, that's truly an influence, as in if the person's already at the end of their life, are they willing to possibly take on lower quality of life for their last days because of having CPR? Does a person have religious beliefs that it would affect a CPR decision? Anybody else in the family have an opinion? That's always a fun one, but not always, it can be. But making the decision as a group, as a family group, can often be helpful because people have had different conversations or have different perspectives. And then just what do you hope that CPR will accomplish? This is a picture of the CPR form that we use in Colorado. And it's pretty straightforward with name and date and birth date and all that. And then whether or not you want CPR. And there's also a section in here that you can indicate tissue donate, whether you would want tissue donated, as in skin or cornea or bone, or any needed tissues, which would then include ligaments and other such tendons and that sort of thing. And you see at the bottom right, there's a place for the physician's signature.
This is one of the few places where a physician's signature is needed because it's an order to be followed by the EMS and anybody who comes in contact with the healthcare facility. Somebody was asking in the chat about a code number for Medicare end-of-life decisions. You don't need to know that. You just need to know that physicians have a billing mechanism specifically for end-of-life conversations, and it's actually, from what I've heard, a fairly robust one. You can ask for a conversation once a year, more than once a year, whenever you want it. It can be with your spokespersons, the person who's your agent. In addition, if you're not able to have the conversation, they just know that they have it. You should have a right to ask for an appointment that's straightforward for end-of-life conversations, and they can bill for it. So don't feel shy about asking for it.
Yeah, thanks, Jane. I guess this would be a good place. You and I were having a discussion with a couple others about the necessity of having an official CPR form with a physician's signature. And there's different information out there. I think all of us that were in this conversation, we're under the, we had the knowledge, we understood that the only way a patient's CPR directive or DNR would be honored is if it was signed by a physician. And yet I've spoken with paramedics who've said, if we see just someone's written it down somewhere that they don't want CPR, like in their file of life or something, that they don't want CPR, or if they're wearing a piece of CPR jewelry that says no CPR, that's not official, that they'll still honor it because they're trying more and more, I think, to honor the wishes of the patient and let the patient guide what they want.
Yeah, so traditionally, it was felt like you need to know the risks and benefits of CPR before you enact a do not attempt resuscitation form. And the law still says that the if you got to buy a bracelet or have some kind of notification that with a necklace that you don't want CPR, that needs to be backed up with a document from the physician. That's the way the law reads. And but it sounds like we've been kicking this around the last couple of days. Somebody in my retirement home asked if you have to have the document in addition to the bracelet. And it sounds like people are, like Susan said, drifting more towards we'll give you the benefit of the doubt and honor you if you have a do not resuscitate indication that we find when we come upon you in a cardiac arrest. the reason that hasn't been traditional is because it's so definitive. I mean, if an attempt to resuscitate you is not done, then you're dead. And so the medical profession would like to err on the side of life. They don't want to screw up and find out that you did not want no attempts at CPR. But people are starting to drift towards we'll honor when we see that, because most people who bother to put a bracelet or a necklace on, that's because they mean that. So
Mhm. Yeah, yes, and that should be honored. And there's also validity to having to have a signature encourages there to be a conversation with a physician who can fully inform you about what is, what your chances of survival to quality of life is,
Well,
et cetera.
there's actually some pushback from the physicians that might influence your decision. CPR doesn't often work. And when it does, like you said, Susan, about half the time of that small increment of people that we resuscitate, quote, successfully, half of them have a disabled neurologic status and don't wake up and don't come off the machines. And, there are exit ramps from that if your family knows that you didn't want it, you can, or if the family said, or you said, oh, I want an attempt at CPR, and the outcome isn't as successful as you define it in terms of quality of life, the ventilator can be stopped. You can withdraw stuff that has been done to sustain life. And so that isn't the end point. You can say stop to the various things that will happen to you after that, if it isn't a quick recovery to what you would consider an acceptable life.
Thank you. It's a very good point. And it is a very tough decision when you've got to withdraw life support, as you know.
Well,
so it's another
yeah.
level.
We'll talk about that a little later, because the New York Times article had some interesting cases of people who were resuscitated against their wishes. I come from an emergency medicine background, and I know that things can be confusing then, and that sometimes we have to withdraw things that get started. Either we withdraw things because they aren't working, or because we find out later that people didn't want resuscitation attempts, and we can do something about that. There's a confusion at the time you're in the ER.
Okay, so you'll share some stories.
Yep.
If you do want to make sure that if you have made no CPR decision and you want to make sure that it's honored, the very first thing is you put your CPR order or your most form, which indicates whether it would indicate that you don't want CPR. That goes on your refrigerator, because that's where the paramedics are trained to look. Sometimes people say, I don't want the green most form on the refrigerator because it's ugly. You can put it on the side of the refrigerator. A copy will do, a white copy will be fine. But if you are out of the grocery store, having that hanging on your refrigerator is not going to do you any good if you're committed to not having CPR. So the recommendation is to buy and wear CPR jewelry. As Jean and I are both, hopefully we weren't confusing you too much, but traditionally a bracelet or necklace needed to be bought from specific places that the paramedics know require a copy of your signed CPR directive from the doctor. So those two places are Medic Alert and a Warden sign. I will send those links to you guys with the follow-up email. But and yet it, at least in the Denver area, maybe just local, that the paramedics are feeling more like, if someone went to the trouble to buy the jewelry and wear the jewelry, they must be serious about not wanting CPR, and they'll honor that request and they will not make an attempt.
I think it's really variable.
Yeah.
Because this is a fuzzy area of the law, and people are extending by rational thinking. Paramedics are beyond what the law says. So,
You know what? And there's a law and there's statutes, and I haven't looked at them for a while, but they're not the same. So they read differently. So like you said, it's very likely very regional, very even from firehouse to firehouse, and as far as the culture goes. So to be on the safe side, I think we'd recommend that people buy their jewelry from a warden sign or medical alert, and know that they're recognizable by the paramedics, by the first responders, as having been backed up by an signed CPR order.
Right. Someplace you should have tucked away that order that documents that you've talked to your doctor and your doctor agrees that this is a reasonable thing.
Right. Just for general info, medical alert ID bracelet is $24.99, and you can add other information on there besides your do not resuscitate request or your no CPR. And then there's something called My Road ID. There's a little picture there. It's like a metal badge or whatever that clips over a health watch, and that has your ID on it. And you can even upload, with both of these, you can even upload some of your medical information, allergies and such, and then your information is accessible by phone or by computer.
So Marcia asks, do tattoos count? There is a classic article in the medical literature of a gentleman who comes into an ER in Florida in extremis. He wasn't in cardiac arrest, but he had a tattoo of DNR on his chest, and he was unstable, but he was stabilized out, and so they didn't have to pursue this dilemma of, oh dear, do we honor this or not? But when he got better, he had this story, which is that he was playing poker, and he lost the poker game. And so he had a tattoo. This was the consequence for him, a tattoo put on, Do Not Resuscitate. And he just never had the money. He never won enough at poker, I guess, to have it taken off the way he wanted to. And so most doctors, after a story like this or two, are very queasy about honoring a informal kind of thing. They don't know what it refers to, under what circumstances it was done. Yeah, you might get somebody to honor a napkin, but again, that's dubious.
Right. Yeah, I've also heard that DNR could be his ex-girlfriend's initials, or or who knows. Oh, and there's no signature on it. If it just says DNR, there's no physician.
Right.
So
I'm right now, I'm up in Breckenridge, and we have a dog kennel up here that's the DNR kennels, and it happens to be the initials of the person's names who run the kennels. And so there's a big sign up here that says DNR kennels. I don't think they admit anybody who is a DNR, but
So are there alternatives to CPR?
well, the alternative is to die. No, I don't know. Tell me what you're thinking about with that.
I don't know. That's why I was hoping, if DNR is so bad for an 80-year-old, what other could be done? What else?
Well, okay. Well, maybe we'll talk about some of that when we talk about the most form, so that, yeah, we can talk about the arc of the end of your life, which is sort of what you're questioning, I think, in terms of, yeah, what your choices are. Let's go on to the most form. So
One more question, Jean, is I've had people say, well, can I write out an advancce directive that says that like defibrillation paddles are okay, but I don't want compression? Can you
some
word it?
some hospitals will allow that. I've seen checkboxes that say that basically if you want CPR, it is it's a package.
Right.
Defibrillation, it's intubation, it's admission to the ICU, etc. If it's successful. So we sometimes get ethics consults in the hospital about, are you allowed to pick and choose? I want this, I want A, but not B, not C. You need to, if you're going to have CPR, you need to give the doctors free rein to do everything full court press to resuscitate you. That's what you're affirming by saying, I want CPR.
Okay, thanks for the clarification. And Jean, this is for you to take over here.
Okay, well, I just wanted to talk a little bit about the fog of the ER, which is where I spent my 30 years. And I remember one particular woman who came in with very bad shortness of breath, and she was very skinny. She was what we call cachectic. She looked like she was near death. And she was breathing rapidly, and she was needing to have a tube put down her. This was not CPR per se, but it was real close, and she was going to get to needing CPR if we were going to bring her back. And I hung on and waited for her daughter, because I thought, I bet there's some guidance from her daughter as to what she wants. And I waited and I waited, and I finally said, I can't wait anymore. And I put a tube down her to breathe, help her breathe. And then her daughter arrived and said, she wouldn't want this. I guessed that was what was going to happen, but I wanted to hear from somebody that was her wishes. And so we said, okay, no problem. In fact, we can, under a controlled setting, you can sit down with her. I can make her comfortable. I can take the tube out, and we can relax with her and give her some medication to make her comfortable. And she died in the ER about a half an hour later. And part of what I'm saying is that sometimes we don't know the CPR, the Do Not Resuscitate order. Sometimes we just don't have the full history. And so things will happen in the ER, and we err on the side of life, and we can always withdraw that. Now, I've spent a few years in the ethics circle, and in the ethics circle, we debate a whole lot the difference between withdrawing and withholding treatments. And the dead white ethicists say, oh, that's ethically equal to withdraw and to withhold. And it doesn't feel the same way. One of the stories in the New York Times was a lady who got CPR, was resuscitated, and had a tube down her. And her daughter said, wait a minute, she didn't want this. And she felt like she would be murdering her mom to take out the tube at this point. It's our role as professionals to help people understand that no, things happen in the fog of the ER, and we will honor those wishes and make her comfortable. And actually, there are times when withdrawing an unwanted treatment is superior ethically to withholding it when you don't know what all is going on. And in a controlled situation in the ICU or in the ER, we can then withdraw and let people have a comfortable death with their family around while they're there to witness it. And yes, it's slightly delayed, and CPR may have happened and they got a breathing tube put in and they're unstable and they have lots of drips to stabilize their heart. And we can say, fine, let's get to a quiet place. Let's turn off the meds. Let's get out the breathing tube, and you can be with her as she dies. So I think that's really important.
Yeah.
Linda Gore had a question here. A friend recently in the ICU was quite willing to be intubated if needed to have defibrillation, but the staff had put a large sign on this door, said no chest compressions. Is that something I can put prominently in the front page? No, I don't think so. Chest compressions are necessary to sustain a little bit of blood supply to your brain while they're getting ready to do the bigger procedures, defibrillation and intubation. So you either take the whole package or you don't. If you're worried about chest compressions and fragility with that doesn't make sense, because you have to buy the time to get the best outcome for the organs that is possible. And that involves doing cardiac compressions.
I see Colleen is asking, where can I get a blank Colorado CPR form?
Google it.
Yeah, you
Or
Google it, it'll come
Google
up,
it.
and your physician should have them in his or her office.
And for those of you who have seen in the doctor's office, the blue-green form, you're right to make healthcare decisions from the Colorado Hospital Association. It has 3 forms in it: the no CPR, the medical durable power of attorney, and a living will. And those forms are all within that packet. And you can tear it out and use that. I just downloaded one today by Googling it from the health department. The form is there and you can print it out.
Let's see, are we ready to go to the next slide, Jean?
Sure.
Okay.
Sure we will. Oh, this is another good question that people have, which is, what happens if I need a procedure? I fall and break my hip and I have a no CPR order, or I need some kind of palliative surgery. I have a bowel obstruction and they want to put a tube in my stomach to decompress that. What happens when that kind of situation arrives? So there's always there should be a policy in every hospital. Usually it's the anesthesiologist that has the conversation with you that says, we would like to suspend your order for do not resuscitate in the hospital because while we do this procedure. And they have good reasons for doing this. Usually they put you to sleep. They may stop your breathing and put a breathing tube in you. Sometimes they give you a med that, boom, stops your heart from some kind of chemical reaction, or you have an allergic reaction, and they want to be able to respond to it. So usually again, here's a good theme, which is have a conversation. They will make a choice will do full resuscitation, limited resuscitation, and I've seen various ways of phrasing this limited resuscitation, which usually it involves the principle of, we will attempt resuscitation if we think we can bring you back to your pre-surgical status, or no, I don't want any resuscitation under any circumstances. Well, why would you say that? We've had a couple of cases that came to litigation, actually, which is somebody who's dying, knows that they're dying in the next few weeks or months, and have a Hail Mary kind of procedure for comfort. And they say, my quality of life right now is not acceptable. I'm going to go for it with this procedure. And if it doesn't happen, then so be it. Then I want you not to attempt resuscitation. Now, the surgeon is allowed to push back and say, I'm not comfortable with your qualifications, caveats about a DNR. I can't operate under that under those circumstances, so I won't do the surgery. Some of them get it, some of them don't, but they also have an autonomy in this situation where they get to be respected. And if they say, oh, I can't be comfortable if in case something goes awry, that I can't resuscitate you, attempt resuscitation. So
And Jean,
go ahead.
go ahead. Go ahead.
So this is the form, a version of it that usually anesthesia will, or somebody, the surgeon, will bring to you to have the conversation before surgery. I want to pin your hip. I'd like to suspend the DNR order during the surgery and in post-recovery, and then we'll re-honor it, which is the way oftentimes the dance goes.
Mhm. And Jean, this is a fairly new form, correct? I think BCH instituted this just a few years ago. It used to be that it was just one of the forms you signed preoperatively was, yes, you'll suspend my DNR.
Yes, used to be my way or the highway from the surgeons, basically. Right. And I remember, 15 years ago, having an ethics consult where there was a patient who was getting into trouble, and it was 30 days after his abdominal surgery. And the surgeon insisted, well, he suspended his DNR for the surgery, so therefore we don't have to honor his request or his wife's request for no resuscitation. And I said, our ethics opinion was timeout. 30 days out is not the same as peri-operatively.
Right, right. Okay. Moving on. Now we'll get into the most form, Jean.
Right. All right. So the most form is a new attempt at extending your wishes for the arc of the end of your life beyond just yes CPR, no CPR. It was started in Colorado in 2007, although this exists in all the states virtually now. It began in Oregon. A lot of things began in Oregon about 25 years ago. And it comes by various names, different name in every state because every state has to put their own stamp on it. But it generally comes under the umbrella of Physician's Orders for Life-Sustaining Treatment, POLST form. In Colorado, it's called the MOST form. And what it does is it translates your wishes for end-of-life care into orders that are based on the your healthcare status now, in how your condition is, how your healthcare is now, in a more expansive thing than CPR attempts. These are called portable medical orders, and they're to be honored by emergency personnel, and we'll go through what the specific treatments are. Go ahead. Okay, so it translates your wishes. Remember, your advance directives in general are statements of what you want, but they're not legally they don't have to be honored, because often you're in a different condition than you were when you talked about those advance directives. So you sit down with your physician and you say, your life expectancy is, a year or two, or you're very frail and you're likely to die. What kind of treatment would you like based on your current healthcare condition? Now, it's misused by physicians and by patients alike. So I came into a residence retirement home and I was handed one. I don't know what the arc of the end of my life is going to be right now, but I was told I should fill one out. You can't by law be asked to fill one out. And so you have to push back when the doctor, as has happened to many of my friends, hands you this green sheet and says, take a look at it, fill it out, and bring it back to me. That's not the way should be used. It should be a conversation that's designed to improve the quality of care for terminally ill patients. So in it, you can affirm or avoid treatments that you don't want to have near the end of life. Primarily intended for elderly, chronically, or seriously ill patients who have frequent contact with the healthcare providers, filled out with the current healthcare conditions in mind. And this is a further attempt beyond the CPR directive to promote the right to self-determination and autonomy. So let's look at the form here. So you may have seen this. It's Vulcan green, and it's 8.5 by 11. And we'll break it down here, but it's something that your physician has, and and he or she will have it and will bring it out if you ask and if they feel it's appropriate, that the arc of your life is pretty well predicted. I have heart failure. I think I'm going to die of it in the next year. I have liver failure. I have pulmonary problems that are getting terminal, or I have cancer that I think are going to be terminal. All right, so look at this, and here's at the top of it, it says, it gives an ID so that you're identifiable and recognized. And you probably will have had advanced directives in past years that are more theoretical. If in the future I develop blah, 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 they need to be brought into this conversation so that they all align and are not inconsistent with each other. Go ahead. There are three main parts. A is, I want attempts at resuscitation, or no, I don't want attempts at resuscitation. If you say yes, and we had this conversation, Sue, before, then you get the whole package. You may get shocked and chest compressions, and you'll get admitted to the ICU. If no CPR, if your heart stops, we'll not attempt CPR. That does not mean necessarily that you can't do other things. So we'll look at part B, but there's a note on it that says, yes, if yes, CPR is checked, part B says full court treatment. Okay.
And can I interject,
Yeah.
Jean, that if you would be choosing yes CPR, don't fill out the most form. Is the advice that I've gotten, because the default is you'll get CPR. So you don't need a form to say that I want CPR. But there have been occasions where someone has filled this out, yes, CPR, then their health changes drastically. They're in a critical life-threatening situation. CPR would be appropriate, but they have this form signed by a physician that says it wouldn't be appropriate. Then they have the form that says, I do want CPR, and now we've got an ethics consult because we're overriding what the patient has indicated. So do you have input on that, Jean? A different take?
That's fair enough. That's fair enough. It's not necessary. So if you want, yes, but there are people who say yes CPR and use this as the form for the CPR directive. So because they feel passionate about it, even though they're within the arc of the end of their life. So go ahead.
Okay.
So B. All right. So in general, I'm sitting in the ER as a professional, and I have somebody come in who's critically ill. They aren't in cardiac arrest, but they aren't able to speak for themselves. And in the first 5 minutes, I would like to know, geez, how far do they want me to go to attempt resuscitation? So this applies when an individual has a pulse or breathing and may require other life support that intervenes. So full court press means the primary goal is to extend life. Yes, I want intubation, breathing machine. I want ICU treatment. I want shocking for cardioversion. This is for somebody who's alive. And I want everything done. On the other hand, comfort focused treatment, a caveat here, comfort focused treatment is a shorthand that medical people use. I object to it a little bit because it implies that everything else that you get is uncomfortable. And that isn't necessarily true. But if the goal is, I want to be comfortable and not have my life extended inordinately by invasive treatments, then you check, I want comfort focused care. And you'll note it underlines that I will be transferred only if comfort needs prevail, require it. Now, I think that the ER, I'm biased because I'm an ER doc. I think the ER is the place where we make this triage decision that, oh, okay, you want comfort focused care. And, you know, I think that we can get hospice for you, or I think you can go back to a nursing home, or I think we can take care of you at home if I call home care for you. So it's sort of the hub and the hub and spoke of treatment decisions near the end of life. Selective treatment in the middle there says, you know, I wouldn't mind going to the hospital. I have a pneumonia. I get some IV antibiotics. I have some kind of infection. I don't mind getting those fluids, but you know, I don't want to go to the ICU, and I don't want people poking and prodding me, and I don't want people breathing for me. This is the problem is that for me in the ER, I want a quick fix. I want to know if you need to be if you CPR, or if you want to be have a breathing tube real quick. And after that, I think all of this requires conversation. The conversation is helped by having the green form and sitting down with the family or the patient and saying, so tell me what you mean by selective treatment, because it probably has to do with the goal of the treatment. I'm in pain because I have an infection in my leg. Sure, I want some IV fluids and stuff. If you think that I'm septic and I'm unlikely to survive this, I don't want to go in. So it takes the conversation after the first 5 minutes in order to clarify what selective treatment means. Okay. This is another one that people like to do. I'm not comfortable with the choices: artificial administered nutrition and hydration. There are some people that believe that food and water are so essential to human life that they always want to get nutrition, and they think depriving people of nutrition is tantamount to murder. But so some people say, no, I want long-term placement if indicated, and short-term, and no artificial nutrition by tube. We have come to learn in recent years that dementia treated with artificial hydration and nutrition, when it becomes necessary, does not extend life. And so that's no longer offered usually for people. This again becomes a complex conversation. And I'm sorry that it's stuck in there, but there are people who feel that they're really passionate about, they want food and water. Would you comment on that, Sue? Thoughts about it?
I don't really know what I could add to that.
Fair enough.
Yeah. I think most people are pretty clear that at the end of their life, especially with dementia, that having artificial nutrition actually is a burden, because
and that's true. But some people psychologically, the family says, no, why would you not feed him?
Right.
Yeah. And so that's probably why this is on the form. Okay.
Yeah, it's so ingrained in us as a culture. I mean, as human beings, that you must feed people, especially when someone's sick. we have to feed them, and it doesn't feel right to not. And
Right.
it's a long discussion around the fact that food and or water is often more of a burden at the end of life.
And the body shuts down, the kidneys
Right.
shut down, you can't absorb nutrition. That's part of the arc of the end of life. And that's why I say the choices are complex and require a complex conversation. It's not an
So-
emergency.
So Jane, what would you suggest, generally speaking? Is it like safe to just check the middle selection of short-term?
Sure. And then you can have the conversation, because all of these things, there is no substitute for a conversation. It all depends on what the purpose is, what the goals are. Artificial administered nutrition is very important for healing surgical wounds, for somebody with a bowel obstruction, for all sorts of indications. But like CPR, when you talked about it, Sue, CPR started out as for the heart too young to die. Artificial administered nutrition started out to gain strength, get protein and calories in you so that you can heal. If you're at the arc of the end of your life, that isn't appropriate. And as you said, it can sometimes make you miserable. You give people IV fluids and they increase their secretions and they can't cough them up and clear them up. It makes them feel worse.
Thanks.
Okay. And then you can discuss this. This can be used by your agent with the medical durable power of attorney or whoever is your spokesperson. So if you're unable to have this conversation, or this is a loved one of yours, you may sit down with the doctor and work through this for your loved one. And that documents that it was discussed by. Okay, and I think we're done with that slide. Okay, and then the signature by that person that you talk to and the physician you talk to. Now, I know in some doctors' offices, it's actually the nurse who has most of this conversation. And that's probably a good thing because they can take the time and they care about this conversation. But ultimately, the physician or the advanced practice nurse needs to sign that. And they need to sign it, the law says within 30 days of it going into effect. And this form is portable. Copies work. They don't have to be Vulcan green. They can be copies that are white. And you move this from place to place. You move it to a nursing home if you are in a nursing home, and then you move it to the hospital. The EMS should bring it to you, bring it with you when they come to the ER. And as I said, I look for it in the first 5 minutes, and then I take it as a prop, and I sit down with the family and or the patient and ask them to tell me what their goals are.
Mm-hmm. And then Jean, would you also recommend that if a person has a hospitalization and then they're discharged, that the most form should be visited, right?
Definitely, particularly on discharge when it becomes clear, if it wasn't before, you're nearing the end of the arc of your life, or okay, on discharge, now tell me what I should tell the nursing home or I should tell EMS for the next time they get called.
Okay. Oh, and DJ, you had asked in the chat if it was mandatory for the most form to be signed, and yes, by the physician, APN or PA.
So I want to talk just about some of the challenges of the most form. This is my mother-in-law and my son. Marion was a fiercely independent person who had an aphasic stroke. That means she couldn't talk. And she came to live near us. And she was wandering around her assisted living in the middle of the night when she fell in her closet and broke 5 ribs. She was a clear comfort care most form we had filled one out for her. And she came to the ER, and my husband and I, who are both physicians, doesn't help in this situation, had to decide what to do about her 5 broken ribs and then 1.5 liters of blood in her chest. We eventually decided that for comfort, she needed to be admitted and to have a chest tube to drain the fluid out of her lungs because she was having trouble breathing because of that. And she needed to get pain medicine. So despite a Mohs form of prioritizing comfort, she was admitted for 5 days to the hospital. And that was the right thing to do at the time for her. And she lived a few months longer than that, but it was because we couldn't relieve her discomfort anymore. The other reason for admitting somebody whose focus is for comfort or who is on hospice, when most of the time you're on comfort care, is if the nursing home can't manage the problem that you've got. They couldn't manage a chest tube in my mother-in-law. They couldn't manage her pain. You have to honor the skills and the limitations of the residents where people live. So that's my story on her. I think we did the right thing. Who knows? All right. I want to also talk about the fact that this is an article that came out in the medical literature a while back, and its disregard of patients' preferences is a medical error. And people are starting to realize that when physicians don't listen to the patient about their advance directives, that should be considered a medical error, just like giving them the wrong medication. Is a medical error. It's a broader thought conception of the idea of medical error, but it was interesting in the New York Times article that there were complex situations where patients' preferences were not honored. One patient just said CPR despite families saying no. Well, that is a medical error if the documents are there and the family is there and you have it. And that should be reviewed as a quality measure. But there's sometimes when it's confusing. There's one case in the literature where a surgeon just said after the surgery, no, I don't care if she has a DNR, you're going to resuscitate. Not going to be on my docket that she died. That's wrong. And that has led to a suit. There was one where an intubation, a patient put a breathing tube in and didn't want a resuscitation. It was very clear that she didn't. And the family sued for the next year worth of nursing home care because she was so disabled from the resuscitation that she required institutionalization. And they said, hey, you have to pay for this. You screwed up. So there are medical errors, but there's also the fog of the ER and of the first few days. And if we can't find family and if we don't know what the outcome is going to be, then you have to accept the fact that sometimes the resuscitation, we're erring on the side of resuscitation.
Jane, there was an instance that I know of in the hospital ER where a man came in cardiac stress, but not arrested. And he clearly stated, I do not want CPR. If I go out completely, I don't want CPR. And his wife was there, hysterical, understandably, saying, do
CPR.
I can't live without him. Do everything. What do you do as a physician? How do you handle that kind of situation?
If it's a real difficult situation. If there's time to sit down and understand her well, we will do that. If he isn't capable of making decisions, we may let her override it, but we will try to help support her and use temporizing measures. So there's ways of helping a patient breathe that involve a mask that don't involve putting the endotracheal tube down to breathe for him. And then to remember that we can withdraw treatments when the dust settles, when her family arrives and says, Mom, you remember that he said that he didn't want this or whatever. People also change their mind. I think COVID taught us this.
Right.
Both ways. People came in very sick at the beginning of COVID when the ICU mortality rate was 80%, and people invoked, they didn't want to be intubated. They wanted to be admitted to the floor for comfort measures and see if they could get over this without requiring intensive care. Elderly people did that. But what was interesting is that I read the story of one lady who had cancer, and her oncologist had told her she had maybe 3 or 4 years to live. She got COVID and she went into the ER and she said, wait a minute, I do not want my life to end now. 3 to 4 years is really important to me. Am I going to see my grandkids grow up a little more? I want to suspend my DNR, which I had because I had cancer, and I thought, oh, well, I don't want a resuscitation. And she withdrew her DNR or no CPR attempts. And that was fair enough. People change their mind. They change their mind when they're peering into the abyss. We have lots of people, not lots of people, but we have occasional people in the ICU who say, no, I'm not ready to go. You know, it has to do with life circumstances. I have a granddaughter who's going to get married in the next 4 weeks. Let's try going for it. That's the problem with written advance directives. I have a baby being born that I want to see. I want to vote in the election.
Yeah.
So people are getting passionate about that.
Right.
So,
Jean, I'm realizing we only have 5 minutes left.
oh,
There is a question about, can the most form apply when an active senior has an accident that leaves them with no pulse or breathing, even though they don't have the medical conditions beforehand?
well, if you've got the most form and the end of your life is there, they will make a judgment call. If this is a reversible accident, like the rib fractures and chest tube, they may decide to try to temporize and buy time to sort out whether you're going to recover from the accident that was unexpected and unpredictable, because that's why you don't want the most form done. There was another question about 10 years ago, the most form. Christopher Columbus, you outlived your most form, or it was done inappropriately. I think you should renew it, and your physician should require you to renew it every year or two, because things change over time.
I'm just looking to see what else. Oh, very pertinent question from Karen about the difference between the CPR form and the most form.
I think that there are a lot of people who feel passionately about not having CPR. And you gave the statistics, Sue, that support this. Do a CPR form until your doctor says, no, we're nearing the end of your life. Go ahead and translate it to a most form. There'll be equivalent for the CPR part of it. But the most form should be used when you know the likely cause of your death. So
thank you for clarifying that. If there's anybody whose questions were not responded to, would you just go ahead and jump in out loud? And I'm going to stop sharing this thingy. Any other questions before we go?
Early on, you mentioned that there were medical jewelry do not resuscitate bracelets that
Mhm.
require you to prove that you have a most form?
No, not a most form, but a CPR order signed by your doctor. So most of the places say fax us your CPR directive, so that we know that this is a valid thing. On the other hand, Amazon has everything and requires nothing.
Yeah, I was wondering, say if I'm at King Soopers and I'm just wearing this ordinary do not resuscitate, what's going to happen?
Well, I think that's what we discussed, that it's going to be variable depending on which paramedic, which team responds, that they're drifting towards honoring that, but the law hasn't caught up with that and still says, well, you need a valid wristband. If you Google Colorado's CPR, no CPR direct or bracelet, there is a form there, but they say, please send us the order that you've had the conversation with your doctor.
And I've had people say they don't like the look of the official bracelets. They don't want to wear that, which is why they go on Amazon or Etsy or find some other pretty bracelet that will work, which it still has to look medical in order for the first responders to even consider honoring it. It has to look like something that they need to pay attention to.
There are also some people, we didn't bring this up, there's some people who are uncomfortable with having a DNR order in the hospital or a no CPR order out of the hospital because they don't think they will get the same treatment. So in the hospital, there's actually some studies that show that if you have a DNR, you may not get as many nurse visits, as much pain relief, etc. It shouldn't happen.
Right.
This is only for, and I had a friend who called the ambulance because she had chest pain. She also had terminal cancer. But the paramedics in her ear sight said to her, I don't know why we're, why she called the ambulance, because she has a DNR, she has no CPR order. And that's bullshit. You know, it's a matter of she's got chest pain. It should be responded to. And one of my roles is to try to teach the paramedics to act their age.
Well, that speaks to the article, that the New York Times article.
Yes.
That she had the woman had a DNR order or a no CPR order, and then ended up with treatment she didn't want, and then ended up quite disabled. And you know, we're just doing the best we can to mitigate, you know.
Yeah, and our goal is to narrow the gap and to have people's wishes honored the most they can. We're not there yet. And part of it's because people change their mind and we have to be sure. But part of it's because the healthcare profession is so fixed on resuscitating and saving and extending life that they're only slowly sliding into quality is as important for some people as quantity, or more important. And we need to honor the way they wish to leave this earth.
Sue, I have a recommendation for the group.
Thanks, Jill. Yeah.
Anybody who has a loved one in a care facility, I am very well connected to the hospice community in the metro area, and a hospice nurse had a horrific death situation. The assisted living in the metro area, the file was not complete, and the caregivers called 911 for this hospice patient, and the first responders weren't aware of a DNR because the file was not complete at this assisted living, and attempted CPR on this individual, and his sternum was concave, and he was. So anybody, my recommendation would be anybody that has a loved one in a care facility, regardless of state, and I think it's totally appropriate to ask to see their file and make sure that their file is complete with their wishes, in that file so that something is not done to them that they never wanted.
Jill, thank
And
you.
that's brings up an important point, thanks.
Yeah.
Which is that you do not have to have a no CPR order in order to be with hospice. 10% of hospice patients say yes, they want a CPR attempt. But you're right, that needs to be documented, and the documents need to be accessible to EMS. Hospice usually tries to teach you not to call 911, but that's not feasible sometimes. The situation is out of hand and 911 gets called, and that they need to have the orders to honor it.
Right. Thank you, Jean. Thank you, everybody, for your attentiveness and your questions. And I think there's still maybe a couple questions we didn't get to, but we've run out of time. So if you want to email me, you can even just respond to the follow-up email that you'll get and ask your question. If I don't know, I'll track down the answer from Jean and we will get back to you. But it's thank you, Jean. I am so grateful to you for all of your expertise that you shared today. And from the Funeral Consumer Society, we are grateful to have all of you and your interest in our programs, in these webinars. It keeps growing. Please, if you have any suggestions for topics or individuals that you'd like to hear from, please send them on to us through the website or my website or whatever works for you. But we would like to, this particular webinar was at the request of one of our members. So we want to be able to respond to that. And of course, I have to say that we appreciate your donations. Many of you have donated. I know some of you have had trouble because our system is not polished yet. We're working on that. We're going to get it, make it easier next go around. But the easiest way to donate, if you feel inspired, is just on the funeralconsumercolorado.org website. And there's a donate button. And you will all get an email with a follow-up from this. So thank you. Have a good rest of the evening, everyone.